Good morning, everyone. My name is Sandra Ramirez, and it's my great pleasure to introduce Dr. Heather Hume. Heather is a former executive medical director at Canadian Blood Services. She was located at head office. And currently, Heather is a clinical professor at the University of Montreal. And she is also a visiting professor at Makerere University in Kampala, Uganda. And today, Heather will share with us some of her very interesting experiences with the blood transfusion system in Uganda. Welcome, Heather.
Thank you very much, Sandra, for the kind introduction, and also to Sandra and others here for inviting me to come and talk to you today about some aspects of my current life. It's a real pleasure to be back here at CBS. I have many fond memories of almost 9 years spent here at head office, and it's a real pleasure to see some familiar faces here in front of me today. So currently, since I left CBS in 2009 to take up a kind of challenge that I'd always given myself from my 20s, that I wanted someday to go and work in some other part of the world. And so currently I divide my time pretty well equally between Montreal, where Sandra said I'm affiliated, as I have been since 1985 with Saint Justine Hospital, and half of my time in Kampala, Uganda, where I do much the same things. I'm a pediatric hematologist there too, although you'll see in slightly different circumstances. First of all, to say I have no relevant relationships or financial relationships to propose for this presentation. So basically what I would like to do today is, or I hope that at the end of this talk you'll appreciate some of the challenges of practicing transfusion medicine in a very resource-limited setting. And to do that, I'm going to tell you a little bit about Uganda and about the blood service there and the hospital there, and try to put that in the context of what are some of the World Health Organization's recommended strategies for improving blood safety worldwide. Now, prior to 2010, I would have had a pretty difficult time of telling you where Uganda is. So I suspect that there are perhaps quite a few people that don't know where Uganda is. Uganda is a small country near equatorial Africa. There's Uganda, right there. Just to remind you of how big Africa is, we sometimes forget how big Africa is. It's roughly 7,500 kilometers east-west at its widest point, and 8,000 kilometers north-south. And that little country of Uganda is about 1/4 the size of Ontario, about half the size of Alberta. It's right on the equator, and I stay in the capital city, Kampala. It's, according to Winston Churchill, the pearl of Africa, and it is indeed a very beautiful place, but often a very sad place as well. Also, to put it a little bit in perspective, to compare some statistics from the World Bank between Canada, the U.S., and Uganda. Tiny country, large population, growing fast. When I started there in 2009, it had a smaller population than Canada. Now it's approaching 40 million. PPP is purchasing power parity. It's an idea of how much spending power people have in the local currency. And you can see that the spending power is very small. And even smaller and sort of more horrifying is the health expenditure per capita, which is exactly 1% of what we spend in Canada. And not only that, in Canada, 71% is public health expenditure. In Uganda, it's only 25%, and that 25% includes both government and foreign aid spending within the health sector. Nevertheless, they are making some improvements, and one improvement that I've seen over the time I've been there is the under 5 mortality, which in 2000 was in the order of 75, 80, and currently these figures from 2014, 55 per 1,000 live births. Still 11 times what we have in Canada. This is a I found a very interesting map. Comes from a site on the internet called World Mapper. Unfortunately, no longer being kept up to date, so I'm showing you something from 2004, and they call it a different way of making maps of the world. And this is a way of making the maps per number of physicians per 10,000 population. And you can see that you might call us bloated in North America and pretty skinny in Africa. And that's not just the way for physicians, it's the way for nurses, laboratory technologists, everybody associated with the medical field. So let's look at the hospital. It's got a grand name, Mulago National Referral Hospital. It's the hospital affiliated with Makerere University, which is the largest university in Uganda, the oldest and the largest, and this will be considered the major referral hospital in the country. If you watched that movie, The Last King of Scotland, you would have seen what is called Mulago, that fairly modern-looking building built in 1960 in the process of being completely renovated. But the pediatric wards are down on the bottom there. They look like barracks, and that's where we see the children. Now, it's a publicly funded hospital, but that doesn't mean there are meals. That doesn't mean that laundry is done. So the patient's attendance means their caretaker, mother or father of children, have to do the laundry. So you see laundry all over the place on the lawn. It's hard to get a picture of a ward because, of course, people are sensitive about that. So once on changeover day, I got that picture of the nurse in the pediatric ward. But private rooms obviously don't exist. Isolation doesn't exist. And we have about one nurse for 50 to 60 patients. And bed count, well, there's not much point about talking about how many beds in the hospital, because in pediatrics, if there aren't enough beds, you put 2 patients in one bed. And in the adult wards, if there aren't enough beds, then you put the adults on the floor. But I think somewhere I have tried to get some statistics. I thought it might be interesting to compare it with the Montreal. You probably know in Montreal, the McGill University Health Center is now a big conglomerate. So Mulago might be sort of similar to that, and I decided to compare them. They have about the same number of outpatient visits per year. On their website, McGill doesn't say what the inpatients per day are. As I said, it's like a rather vague figure for Uganda. Look at the number of deliveries. Very fertile country, Uganda. Just calculate that. That's like about 1 delivery every 15 minutes. Somewhat fewer surgeries. But I was surprised to see that the amount of blood we use is about the same. So we do have quite a bit of blood in the hospital. That represents, so I've said 17,000, approximately 17,000 units of either whole blood or red cells, corresponding to about 12,000 donations. So I'll just explain that a bit to you. We use a lot of whole blood, but not uniquely whole blood, and I'm going to talk a little bit more about that. But what we do have, fortunately, is some whole blood units, in fact quite a lot of them, are divided into 3 by the blood supplier, and they call those PD packs. And so it means that we don't have to enter a unit of whole blood when we just want to give a small amount of blood to a patient. So that allows us to make the blood go a little farther. So that's how I'll get to the 12,000 donations, which represents roughly 5 to 6% of the blood supply of the people. So for all those patients and all that blood, here are pictures of 2 of the laboratories, and you can see what the main hematology laboratory and the main blood bank. And we're not too cramped for space, but perhaps that's because we don't have a lot of stuff to put in the space. It's pretty empty in that hematology lab, isn't it? The back room, we have a CBC analyzer, which works some of the time, but that's about it. And in the blood bank, there is a centrifuge. And if those of you, I don't know if there's some people from the lab here, but if you look carefully, you'll see that the tests are done on that tile. Do you see? Technologists in the room who remember the tile test from a long time ago. Okay, now turning to the WHO and what some of their strategies are. And I put here in blue the ones that I'm going to spend a little extra time on. But just let me go through it. So WHO recommends that all countries should have a national coordinated blood transfusion service. And having sort of been brought up in a national blood transfusion service, I do agree with that, mostly. But it is challenging in parts of the world, especially where the roads are very bad. And so I'm not sure that this is actually should be a goal 100% of the time, but for most places, and indeed that's the situation in Uganda. 100% voluntary unpaid donors. That would seem like a motherhood statement, a no-brainer, but we'll talk a little bit about some of the debate around that one. Testing of all donated blood, that's particularly thinking of HIV, HPV, HCV, and actually there's been great progress made worldwide for that, and I will only touch on that briefly. Production of blood components versus the use of whole blood is another area of debate, and I'm going to say more about that. And then WHO is very concerned with the appropriate clinical use of blood, and again I will make some comments of that, but I personally think rather than thinking of the appropriate use with respect to indications, not to say that isn't very important. I've spent a huge amount of my professional life talking about that and working with that. But what is really urgently needed in these countries, I think, are safer practices at the bedside, right unit to the right person kind of thing. So I'm going to talk about that. Comprehensive quality systems. And I will confess that sometimes the quality systems at CBS seemed a lot to me. But I can tell you, when you go someplace where they don't exist, you realize how lucky we are to have good quality systems. Hemovigilance, very important according to WHO, but I won't address that today. So the Uganda Blood Transfusion Service, as I said, we're very lucky there to have a national system. It's been in place for a couple of decades. It's actually quite old, but it's been strengthened over, I guess, about the last 15 or so years with aid money, and PEPFAR in particular. That was a fund started by President Bush in the U.S. To decrease AIDS worldwide, and blood suppliers got some money for testing with that. So we collect approximately, the UBTS collects about between 5 and 6 units for 1,000 population. We'll see where that places them worldwide. I think at CBS it must be around 30 to put that into context. It is a system that has 100% anonymous volunteer donors, of which 58% of the donations coming from repeat donors. So that's a real, that's really remarkable actually, given for Sub-Saharan Africa. Viral testing is done. HIV is an antigen-antibody combo. And they do pretty well at having a lower rate of HIV on their blood donations versus the general population. But still, can you imagine being in a place where close to 1% of your blood donations are positive for HIV? You hate to think that there might be errors. This is where you want to have your quality systems working. What does WHO recommend for donations per 1,000 population? They say it should be, no matter where in the world, it should be at least 10 per 1,000 population. And here are their figures from the WHO website about what it is in high, medium, and low income countries. So for a low income country, Uganda is not doing too bad, but I think if the next, but you'll see in a minute. This is just saying what is the current situation, again, from the WHO website. And in red are those countries where it's less than 5 donations per 1,000 population. The green where it's more than 30. Actually, Uganda in this picture is in red, but now it would actually be in orange. So in Africa, the demand far, far, far exceeds the supply. Now, this is not based on actual figures because there are pitifully low or few amounts of figures about blood supply and demand and needs in Africa. So this is something that Troy Lund put together, looking at some publications and making some estimates. And so don't take it as actual fact, but more the impression that this gives you that any one of a number of things that blood is needed for in Uganda could use up the whole existing blood supply. So we're really stretched. And here's a picture of what it looks like in Malago Hospital. And on an average day at 3 p.m., and I said 3 p.m. here on average day, this was an average day just last November, at 3 p.m. because we get our blood about 1 p.m. And there's a frenzy in the blood bank at 1 p.m. because everybody knows that's when it comes. And by 3 p.m., we usually have no Group O blood. None. Zero on our shelves. And often no A. We're usually pretty rich in AB, which doesn't do us much good. On an exceptionally good day, we have 2 units of Group O blood. I can tell you when I first arrived there and knew about obstetrical hemorrhage and realized we had no Group O blood, it made me extraordinarily nervous, and it still does. It's a terrible situation. And one of the projects I'm hoping to do this spring is to start actually monitoring how many people die because of lack of blood. But the residents tell me every time they work at night, every night, somebody in our hospital dies from lack of blood. Okay, changing gears. 100% voluntary blood donation by 2020 is a WHO goal. Just to recall donor types, voluntary non-remunerated donors, that's what we're all used to in North America. Paid donors really are disappearing worldwide, even in low-income countries. That is paid when we're talking about whole blood donations for labile blood products. We're not talking about plasmapheresis. But where the debate comes in is the family replacement donors. So these are not directed donations. These are somebody in your family needs 3 units of blood, and they can get 3 units of blood, but then you have to round up 3 people to replace that blood. And so are they voluntary or are they not voluntary is a thing. And WHO considers them not voluntary, potentially dangerous, and that they should be eliminated. But that's where the debate comes in. As you can see, still about half of the countries that WHO surveys have greater than 50% of their donations from family replacement or paid donors. That was between 2008 and 2013. And again, this is a map that shows the percentage of voluntary unpaid blood donation 2008. And in green is where it's virtually everyone, so Uganda is green rather than red in that one. And of course, the thinking that the voluntary donors are better than the family replacement donors is the concern about the TTI markers. And just to say what they are, and let's just look at the HIV. Again, this comes from the WHO website. And in high-income countries, of course, HIV is very low. And you go down to the low-income countries, and you can see that it's uniformly pretty high, about what I showed you in Uganda. But this is a slide taken from work put together by Jean-Pierre Alain, who is actually quite a proponent of saying we shouldn't throw out those family replacement donors, and I think he has a good point, actually. And again, we're just going to look at the last column, and here what he's done is looked at the infectious disease markers confirmed in family replacement donors versus first-time volunteer donors versus repeat donors. And you can see for each of those 3 markers that it's more or less the same for the replacement donors and the first-time voluntary donors. Most of those replacement donors would be first-time donors. So, you know, one marker might be a little higher there, but they're not so different. Where the big difference comes in is with the repeat donors. Not surprising that the repeat donors are universally probably our safest donors, and certainly the difference between first-time, be they family replacement or completely voluntary, and repeat is bigger in these countries with higher incidence of those markers. So overall, the advantages of the family replacement donors is that they're definitely less expensive, and these blood services are working on minuscule budgets, and they may be more readily available. The disadvantages are the concerns about the TTI markers. I think that what Jean-Pierre Alain is trying to say is it's not so different, but that's looking in places that at least have something of a quality system in place. I think if you get out in the in the rural areas where there's virtually nothing, I would be very nervous about those donors. But looking forward for what these countries want to come to, they're not going to be able to build a sustainable, adequate blood supply using those family replacement donors. And the question is how to get them, as always, any kind of first-time donor to become a repeat donor. Okay, that's the debate on family versus volunteer donors. Now looking to the debate on whole blood versus components. And I'd say, again, from the WHO website, you see that in high-income countries, not surprisingly, almost all whole blood donations are made into components, and about half and half in low-income countries. And what should it be? And certainly the agencies such as PEPFAR and external agencies have been pushing countries, low-income countries, to make components. And WHO appeared to be doing that as well. Now, I'm not intimately connected with WHO, so I can't honestly say that I know the current thinking on that. But my sense from looking at their website is that they may be backing off that a bit. And when I think about this, I often think of an ad in Transfusion, for those of you who read that review. Near the front, recent months, we've always seen this little lady sitting up on a bench and says, one size doesn't fit all. And I think that's really the approach we should take in this debate. So the pro, you know the pro. Just give the patient what you want and use the unit the most, and you can use one unit for 3 or 4 whatever things. That's true when you can send your plasma for fractionation. But in resource-limited settings, first of all, it's very expensive to make components. They have almost no money. Many transfusions are for acute hemorrhage. Whole blood would be quite fine. And then it leads to waste because with those figures for HIV, donation positivity, and the kind of quality systems that are or are not there, I don't think there's any fractionator that's going to touch that plasma with a 10-foot pole. So this is a debate ongoing, but I think definitely would not want those countries to go to 100% component. On the other hand, these countries, including Uganda, are trying to do more sophisticated medicine. And at the hospital I'm at, we do have those PD packs that I talked about. I don't actually consider that real making components. That's just a really good way to divide up your whole blood for use in pediatric patients. But we call those red cells. I won't get into it. They actually are red cell units in segment. And I think all the plasma goes to the garbage. But there is a cancer center. It's the country's only cancer center. There is a heart center. Some teams come down. Open heart surgery is performed. And even poor countries are looking eventually to do this. So some components are necessary. And this is from a study that a medical student did when she was with us, looking at what is the mix of blood that we use. So you can see it there. It's 60% whole blood, and then there are these components. The other surprising thing from this study that this very impressive medical student did in her few months in Uganda was to look in a university center how we use blood. And you've probably heard that in Africa all the blood goes for obstetrical hemorrhage and malaria in children. And I think in rural Africa that remains true. But in city Africa, so there's, like many places in the world, there's big urban-rural divides. And in our urban hospital, actually we were quite startled to find that 1/3 of the blood actually goes for the treatment of cancer. And this is true both in adults and in children. And we were also very surprised at the small amount for malaria, only 2%. Well, malaria is decreasing worldwide. And with that, the need for blood. As I say, this is not representative of Africa. Unfortunately, there's very few figures for all of Africa. But it does tell you that in some places it's changing. So there is some need for components. Now I'm going to come to the hospital side. And this is a slide that has been given to me by Dr. Sunny Zeke. He is, as those of you who know him, a very big proponent of safe transfusion practice in hospitals. That's certainly been a huge part of my own career. And it has been a big part of what I think is so important for transfusion in the developing world. And it reminded me very much of being at Saint Justine in the 1990s, when it was a time, we were just getting over the terrible tragedy of HIV transmission in blood, and there'd been such an emphasis on new blood suppliers, well, CBS was coming into being, on proper testing, on making a safe unit of blood. And almost no attention and funds being directed to the hospitals to say, yes, it's obviously necessary to get a safe unit of blood, but it's not sufficient. You have to use that unit safely once you've got it in your hands. And I think, gradually through the 90s and the early 2000s, more resources were put. It was recognized that that was an important part of blood transfusion. More resources went there. Well, we're sort of at that 1990, 1995 place in Africa because the units are safer. There's still a long ways to go. I think the biggest ways to go is with quality systems, but the units are very much safer than they used to be. But boy, some of the ways they get used in the hospital, there's been no attention and certainly zero funding for that aspect of blood transfusion. So I talk a lot about this in Uganda. Now, if you start off, if I were just to go back to that, if you're looking at the hospital, and again to say, it's not just the product, the process is important. And the first thing in the process is the transfusion being ordered for an appropriate indication? And trying to use blood appropriately with respect to a proper indication is a huge challenge in every hospital worldwide. And like so, it is in Africa, but it has some extra difficulties there. By the way, WHO is very concerned about inappropriate use, and when they use that term, they mean, did the patient really need the transfusion? Yes, I think there is some inappropriate use, but I don't personally think that's where the biggest hospital problem is. But here's something, I'm going to put this all at once. The first year I was there, we did a little 3-day audit, and we haven't updated it, so it's from 2010, and I do hope some things are better, but some things are probably the same. But one of the things we wanted to look at was how often a pre-transfusion hemoglobin was taken. And we found that in the pediatric ward, which is the upper table, 82% of the unit, for 82% of the units transfused or assumed transfused, a hemoglobin level had been done. But in the adult ward, in the lower table, only 12% of the time had a hemoglobin been done. So there's your first thing. To know, it can be very hard to evaluate clinically the need for a transfusion. I mean, sometimes it's obvious, but sometimes it's a real gray zone. And not having a hemoglobin level might lead you to transfuse more often than you should. Why wasn't there a hemoglobin level? Well, in the pediatric blood bank, there is a hematocrit machine which could almost always be used. And in the adult ward, first of all, it was closed at night, and then some weeks the machine was broken down, it had been repaired, and some weeks the reagents weren't there, and the next week something else wasn't there, so that it often wasn't done, and I think physicians just got frustrated and didn't do it. So here's some place that needs improvement. I did chuckle when we did this audit that some of the times when they couldn't get a hemoglobin, remember we're in Uganda, and I'm the minority there, people are black, but people who need transfusions are sometimes described as paper white. So, no, so I presume that they needed it. Just to go back, but look in the children, the median pre-transfusion hemoglobin was 3.8. So I don't think we're giving too many inappropriate transfusions. In the adults, they occasionally got up to 12. I don't know why. But a bigger problem is ensuring ABO compatibility, and that one is hard, and it's hard for so many reasons. First of all, our hospital doesn't have any patient identification bands. We're not unique. They hardly exist in Africa, but we have talked a lot. We actually have a hospital transfusion committee, and we talked a lot about if we did have them, what would we put on them? Africa is an oral society. How you say the name matters, but how you write it doesn't much matter at all. And so I found charts. These are real examples, and I would ask the parents, are there 2 Zs or 1? Oh, doctor, you just put whatever you want. And then this second example just happened to me a few months ago. And I look at the file, and there's one name, And we actually had in the sickle cell clinic where I work, we have electronic file. So I looked in the electronic file and there was one name, and I looked on the paper file and there was another name, and they didn't even look anything alike. And so I said to the mother, this child has two different names. She said, oh yes, I call her this, and her father calls her that. She said, when you come to the hospital, you have to pick one name. We can't deal with two names at the hospital. And then in the audit that we did, this is just a little piece, and I took it because see how easy it would be for names to get mixed up? Look in the first column, how many names start with NA. And this is out of a total of 36. And look at them all that start with NA. You see they're all females. Females, brothers and sisters don't necessarily have the same surname. And males' surnames don't start with NA, and females do. And so there you are. And if you look over to this, because I just took it an extract, I'm sorry there's no label on what this is, but this isn't the full name, by the way. This is just the first three letters of the name. But this column is a pre-transfusion hemoglobin. Now tell me where there's inappropriate practice there. And even the 9.6 was a child with sickle cell disease and a stroke. So it was indicated. But look at those levels. We see those levels every single day. So that's the difficulty of the name. Now, what about the birth date? People, especially people older than about 15, don't know how old they are. And as I was first preparing this, not this presentation, but the first time I gave something similar, I just happened to be reading a book called White Teeth, not by Zadie Smith, but by somebody else in Uganda. All these were, I'm just going to move over here. All these were told to me by my maternal grandfather after I had grown up into a little boy. He'd come home on a short leave when I was born, and he had written down the name of the day, the moon, and the year, and had kept it in a small book in a small wooden box. Unfortunately, when I began to smoke, I used leaves from the book to wrap my tobacco. And now I don't know how old I am. But does it really matter? And this is it. People didn't seem to think it mattered. Or I don't know, I'm not how old I am. He has an idea how old I am, but the exact date I was born. So this is another problem for identifying people. They don't know how to spell their name. They don't know when they're born. What would you put on that band? Anyhow, fortunately, the younger children are beginning to know, the parents know, because there's a big campaign in the country to now, nothing's computerized in the hospital, or not very much, so we're back to these old problems. And we actually had a very, very sad, serious transfusion reaction in April of 2015. So I set out in another bout of teaching, and it didn't take me very long, unfortunately, to find examples of things not very well filled in or written. So of course, we use these for teaching, and I'm going to have some of the slides I'm going to show you now are from teaching opportunities that we've really tried to make the most of. So I'm going to go into a little bit of technical stuff now, because you will see how that is among the challenges. What do we actually do when we prepare a unit of blood for transfusion at the hospital? Well, we do the patient ABO grouping, but for those of you in the lab, we do forward grouping only on our tile. We do test the patient for RHD, 98% positive in Uganda. Tough luck if you're RH negative, tough luck. We do not screen for irregular red cell antibodies. We do verify the group, and I will not tell you how many times we find that what's in the bag is not what is on the label, and that has at times led to problems. The cross-match is a room temperature, all using our tile, and we don't do any 37 anti-human globulin testing or any equivalent. So that would not be considered very ideal testing. But even with that little bit that we do, when we did our audit back in 2010, we discovered that we don't always do it. That I hope is improved, but I know it's still not 100%, and I'm going to show you some of the reasons why. We wondered if it had anything to do related to the urgency of the transfusion or the time of day of the transfusion. And we couldn't pin it down to anything in particular. Now that was just 3 days. It was the middle of the week, but we really couldn't figure out why it so often wasn't being done. And when we started speaking to clinicians about this, they didn't know it was happening. So they were unaware and a little bit aghast. And part of the reason they weren't aware was because at that time there was no paper that went to the floor to say it was done. And does it matter? As I say, alluded to, I have unfortunately known or been actually part of some deaths due to ABO incompatibility. I personally think that it's the most common cause of death from transfusion other than not getting the transfusion in Uganda, but that's my personal opinion. But we did do a study about acute transfusion reactions, and in that study there was a 43-year-old female who was receiving blood, and the only reason she was being observed was because we were doing the study, and at 1 hour into the transfusion she told the physician doing the study that she felt like there was electricity going through her body. And fortunately he didn't think she was a little deranged. Fortunately he stopped the transfusion, went back, tried to figure out what had happened. That was not very easy. But she had been somehow labeled as being group AB and got AB blood when in fact she was group O. So I figured this transfusion study we were doing, perhaps it saved her life. But why are there missing cross matches? So we knew why there weren't. But often there's not a technologist. And when there's not a technologist, they'll just come and get a unit of blood. And the blood unit may or may not be properly labeled. Or an intern or a resident, they do all kinds of cross-matching, but they have no idea what they're really doing. The idea of training somebody to do a job is just not part of the culture always. But I think it also basically comes down to a lack of understanding the importance of being very careful. And this is where it really, for me, highlights the need in low resource settings for transfusion medicine education in general and quality systems education. So those are definitely challenges for the future. Now, I'm going to get a little bit technical here, so I'm sorry for the people that won't quite follow this, but I wanted to give the laboratory people just a little flavor. I said we don't do 37-degree cross matches, so we don't test for irregular antibodies. Doesn't matter. We know, those of you who are a little bit in this field will know that there's a lot of talk in North America about the fact that sickle cell patients, so most of them are black patients, make a lot of antibodies. And it is part of the reason they make so many antibodies because the antigens on the red cells are different or present in different frequencies between whites and blacks. And that's the reason. And that is a good part of the reason, but it's not the only reason. And there are a couple of interesting studies that have actually been carried out by Ugandan physicians in Uganda looking at the rate of alloimmunization, red cell alloimmunization in Uganda. So obviously, same donor, same recipient population. And the bottom line is what's shown in red there without going into details on this slide, and it's about 6%. He did it in sickle cell patients, and he did it in patients non-sickle cell that had received a few transfusions. So it's about 6%. Those would all be considered clinically significant. The question is that important? Is 6% important in a country that spends so little money on the healthcare system? So I think that's a real valid philosophical question. But there are manuals produced by the Ministry of Health that says it's important and says that this shall be done and looked for. So we could identify antibodies, but then what would we do? The blood service can't give us phenotyped blood. So we'd say, I want Cal-negative blood, and they'd say, too bad. So we're trying to do something. We have some of the necessary equipment. I'm going to show you a piece of that. We do have support from the lab management and the technical staff. And again, I think this is a one-size-doesn't-fit-all kind of thing. I don't think it's realistic that we can do it for all patients, but we could do it perhaps for some of the patients. You can start with baby steps, and we could do it for the patients that are transfused the most repeatedly, who are our sickle cell patients who have had strokes. Now, okay, we're going to do it. You can't buy screening cells in Uganda. So what are you going to do for your screening cells? Well, I happen to be group O and I know my phenotype. And my poor husband has got a few picks in his arm too. Well, sorry, but you know, sometimes you can't do it the way you do it here. Um, and then we can't do identifications, but we can try to phenotype. I'm not phenotype. Do a cross match. Do a 37-degree cross match, which will help you the day you find your antibody. But 6 months later, if that antibody's gone, it's not ideal. But we're getting started, and this is Caesar. And Caesar is a superb blood bank technologist. He has had training in Minnesota. He went on, for any of you who know about the American Society of Hematology's visitor training program, he got one of those awards. He went to Minnesota, worked with Dr. Jeff McCullough, learned something about quality essentials. He understands them. He knows about antibody screens and identifications, and so we've started doing them. There's his notebook. He's scrupulous in the way he writes down what he does. I call this the recipe box. It reminds me of when I started at Saint Justine, because we keep no records. That's another thing. There's no records in the blood bank. So we now have a couple of records of the antibody screens we've done on some of the sickle cell patients. And just there, it isn't there, but he was starting off doing everything manually. You know, you wash manually. You remember that, Jackie? Yeah. But thanks to CBS, we have an automatic cell washer, and we've just put it into use, and it was really exciting for us. Caesar, they were very serious in pictures. I couldn't get Caesar to smile, but Caesar was thrilled because he said, I did 4 or 5 in 1 hour. He was, and so there we are with our CBS donated automatic cell washer, doing our 37-degree Coombs antibody screens and cross matches. So there's lots more that I can tell you, but I expect I've pretty well used up my time. But I did have to chuckle when I saw this wheelchair at the hospital. This is a Ugandan-style wheelchair, and you know, we often cannot use the same solutions as those we would use in high-income countries, but it doesn't mean that we can't do something, and that's what we try to do. And now just let me end on a slide that I use often in Uganda. One of our little sickle cell patients, very serious-looking girl, getting a transfusion in our sickle cell clinic. There's a blood donor drive on the lawn of Mulago Hospital. There's something that's up at the Uganda Blood Transfusion Service. Blood is like a parachute. If it's not there when you need it, chances are you'll never need it again. And I used to say give blood, but now I say give it more than once. Thank you.
So thank you very much. That was an excellent presentation. We'll open the floor to questions now.
Thanks. That was excellent, Heather, and very interesting. Could you comment on your experience in Uganda? Would you see that the same in the rest of Africa? Would it be better? Would it be the worse? Would it be the same? Do you know about that?
I can comment, although it will be what I think from my little bit of experience in other countries, but I don't really have a huge knowledge of other countries. But I do believe, from the little I've traveled to other places and reading in the literature, that with respect to sub-Saharan African countries outside of South Africa, South Africa is a whole different ball game. You know, this is, and all the countries of South Africa, including Namibia, Botswana, are at a different level, a level of a middle-income country. But if you think of those countries around the equator, I think Uganda is very typical. In some ways it's better because it has this national blood transfusion service, and not all countries do, although in general East Africa has better organized blood supplier systems than I think West Africa is more fragmented. But with respect to such things as what it's like in the hospital, Uganda might be on the poorer side, but not doing complete pre-transfusion testing, for example, would be very typical. I think most of Equatorial Africa, and talking to people in Equatorial Africa, they only do the simple kind of pre-transfusion testing that we do. I don't think that I think the problems with quality systems exist in hospitals across Equatorial Africa. So it's, I would say, fairly representative, although on the poor side. Say with respect to Kenya, Kenya would have more resources, for example.
Really nice, Heather, and I guess I forgive you for abandoning CBS, all the good work you're doing in Africa. Have people considered using the kind of portable hemoglobinometer that we use on our donors instead of lab machines as a pre-hemoglobin test? Because it's very inexpensive and not a lot of moving parts or reagents with those.
Yes, and actually something similar to that, Mindy, is used in the pediatric blood bank lab, because there's a pediatric blood bank in the hospital and the adult, and that's why they more often had a hemoglobin level than in the adult where they did not. So that would be good. So it has become recently somewhat better in the adult lab, but even with that, there's a problem. And in the sickle cell clinic, we have use HemaQs, except you run out, and there isn't anything. I didn't show you a slide, and sometimes I've shown a slide, and when I give a talk similar to this, about the things we've run out of, and there's virtually nothing that I can think of that we haven't run out of at some time. And so, yes, it would be better. There's still a problem when you run out of it. Another problem throughout Africa, although fortunately not in our hospital, is when the electricity goes off. So lots of places don't have electricity. So there's lots of studies being done about innovations about just about anything in healthcare that can be done without electricity. But yes, that's where I think, coming back to simple things, you don't need a whole CBC. You could, a good hematocrit. And another thing, though, I've noticed in our sickle cell clinic is that the maintenance of the machines and the quality control of the machines is also far from perfect. So I've also seen a lot of results that I look at and I think, ooh, we need you, Christopher. I think that's one of the really big challenges going forward.
So we have a question from, and I apologize if I pronounce your last name incorrectly. We have a question from Andrew Pavlovsky, who wants to know if, I don't know if you know the answer to this, if Canadian Blood Services has a program where they can donate old equipment to third world countries.
Well, I don't know the answer to that question, but I can tell you that I often email David Howe. David, those blood boxes, aren't you replacing the blood containers? Isn't that true? What are you doing with your old ones? I will take them. And we did have the donation of the cell washer. Unfortunately, one of the problems that I didn't realize when I first took the equipment, and the cell washers came, when you remember, labs were being amalgamated and downsized, and we were a beneficiary of that, and thank you very much. But there's a difference in voltage. Is it voltage? Some of you know something about electricity, which means that we have to buy transformers, and in the big scheme of things, I suppose they're not very expensive, but the hospital has no money for it. And then because they're rather valuable things, you're afraid of them being stolen. And so we're now looking more to Europe for equipment donation, but that doesn't mean that if there's something, give me a call. But is there something organized? I don't know, but those blood boxes don't need electricity, so.
Thank you, I really enjoyed that. Is there any sort of process for donor screening, or do you just take everybody? Or are they asked any questions, or are there any ever deferred?
No, it's it's very hard to get precise figures about anything. I'm sure there are donors that are deferred, but I don't know. That's actually an interesting question. I don't think I've ever asked at UBTS, but they do have a blood donor questionnaire. They do have a screening. I don't know if you maybe probably forgot to mention it, but I don't know if you can go back to the slide that I had about UBTS. With the PEPFAR money, they have a very nice room, a nice, really quite confidential sort of room for screen. You can see the woman standing outside the door, and it's in there where they would screen their donors. So that's really a very nice setup. And they have a questionnaire that has about 12 questions. So we're a far ways off. But how rigorously that is used and how often donors are deferred, I don't know. It remains that in the general population, the incidence of HIV is 7%, and in blood donations it's 0.9. So somewhere along the line, there is a selected donor population.
Thank you, Heather, for a very interesting presentation. This is more like a philosophical question. Is there any resistance to blood donation due to cultural or religious beliefs in Uganda?
Again, working more on the hospital side than in the blood donor side, I don't know all the details to give a really good answer to that question, Sandra. But I do see it mentioned often enough to think that yes, it is a problem, or it is a challenge. Cultural opinions about giving blood and fear of giving blood and so on. And I also think that the approach to overcoming that must be very different. I would think it would have to be very different in Africa than it would be here. And it may, for one thing, be much more culturally sensitive, the kinds of questions that need to be asked. If you consider Uganda made it into the news a few years ago with a law about homosexuality and not insignificant number of people who thought that homosexuality should be illegal, then what does it mean if you ask a person if they're homosexual, and if they answer they may really incriminate themselves in a country where there's those attitudes. So I'm sure cultural aspects do come into it. Yeah.
I would like to thank Dr. Heather Hume for coming to Ottawa to do this presentation and to make this presentation available across Canada through our webinar.